Welcome to MenopauseWize, your go-to podcast for all things evidence-based in the menopauseverse. I am Dr. Sukhpreet Patel, an MD gynecologist, a menopause health advocate, a postmenopausal woman, and the founder of MenopauseWize. And I'm so excited to have you join us on this journey. Whether you're a healthcare provider looking to stay on top of the latest evidence-based practices, a woman navigating your own perimenopause or menopause journey, or a partner or family member eager to support a loved one, this series is designed with you in mind. Our mission through MenopauseWize is to close the menopause knowledge gap by bringing you the latest research, expert insights, and practical advice, empowering you to make informed decisions about menopause and perimenopause. Hello and welcome to today's episode of the MenopauseWize podcast on hormone therapy for bone health. Is prevention better than treatment? With Dr. Jocelyn Wittstein. Dr. Wittstein is an orthopedic surgeon specialized in sports medicine. She is currently an associate professor of orthopedic surgery at the Duke University School of Medicine, where she fulfills the roles of a clinician, a researcher, and an educator of medical students, residents, and fellows. Her research interests are the female athlete across the lifespan, post-traumatic arthritis after knee injuries, frozen shoulder, and the musculoskeletal syndrome of menopause, among others. Dr. Wittstein is the president of the Forum, Women in Sports Medicine, a core leadership member of the Duke Female Athlete Program, a member of the Milken Institute Women's Health Initiative, and the author of the Complete Bone and Joint Health Plan, which I recently enjoyed reading and would highly recommend for women looking to create a complete bone and joint health plan. And I love the way you start off. I love the quote, good health isn't a gift, it's an accomplishment. I absolutely love that. I think it's such a powerful statement and so empowering for women to know that it's in your power to do something about it.
Yeah, I love that statement too. The only hesitation I had with using it, because I do really love that quote, is that sometimes we do have non-modifiable risk factors that we can't make go away. And I hope no one reads that quote and thinks that I'm minimizing that, because there are things that we can't change sometimes. And so there are some things that are in our power and some things that aren't, and that's okay.
Thank you for clearing that up. Okay, if you can start off with the basics, just letting us know, our audience know, what really happens to our bones during the menopause transition and how do hormones, what role do they play in our bone health?
And some of this I know you know well, but in general, we accumulate bone mass and bone density in our tweens and teens and 20s, and then peak with that bone density at age 30-ish. And then there's a generalized decline over time in that bone density. And this can typically be like 1% per year. And then when women hit menopause, whether that's early menopause, premature, or it could even be medically induced, in the absence of normal estrogen levels, there is this shift in the balance of bone, of making bone and breaking down bone. And one of the key things that estrogen does to help us maintain our bone density is that it inhibits cells called osteoclasts, which are the cells that resorb or break down bone. And when those cells are able to be produced more or live longer, there's more breaking down of bone than there is building of bone. And then you get this more accelerated loss of bone density, which may be more like 2% per year. And so obviously that's a significant acceleration. And if you hit menopause at 51 or 52, you could theoretically have this decline of as much as 20% over a decade, something like that, whereas before it was declining much more slowly. And then, as you also know, menopausal hormone therapy that includes estradiol can then stop that process or be protective of bone and not just slow the decline, but can actually increase bone mineral density. And there are lots of studies of that, different routes and durations and doses, but that's the general effect of that type of medication.
And the terms osteopenia and osteoporosis, could you simplify them for our audience?
Yes.
Just to lay the
So
base.
those are specific cutoffs on a DEXA scan, which is a scan that looks at your bone mineral density. When you get a DEXA scan, your bone density is compared to a healthy 30-year-old, basically. And if your score is -1 to -2.5, that's the number of standard deviations below that of a healthy 30-year-old. And if you're in that range, that means you have osteopenia or low bone density. And if you're greater than or worse than negative 2.5, that would be defined as osteoporosis.
And is bone densitometry the only way for us to figure out if you're osteopenic or osteoporosis or have osteoporosis?
No, there are other means. There's also CT scans with volumetric bone density. There are especially helpful things that can be overlaid on a DEXA scan called the trabecular bone score. So it's like an add-on measure onto a traditional DEXA scan that indicates more kind of quality of bone, more so than just density. And then there's something called REMS, which is another non radiographic way to measure your bone density that has a little bit more user variability. Isn't as much considered the gold standard, but I do find that sometimes people are getting a DEXA scan and then getting like another measure. And I think it's best for people to, at least if you're trying to monitor progress, to stick with
Mm,
one.
mm. And what would be your preferred modality?
I think right now the way to get like the most information possible would be a DEXA scan that also includes the trabecular bone score.
All right, that's good to know. And if we are basically, if you're using hormone therapy, we know that currently hormone therapy is FDA approved for prevention of osteoporosis
Yes.
and not for treatment. And it always intrigued me why that was not like at a minus 2.5 T score and a minus 2.4 T score, woman with either one of them. The basic biology and interaction between
Right.
estrogen and bone is still the same. So, what
I know. I think
makes it
it's,
different?
yeah, I think it's somewhat illogical a little bit, but I think it stems from the fact that if you look at studies of hormone therapy that includes estradiol that are done on people, say, with osteopenia, and we have data on fracture prevention risk, like how much it lowers fracture prevention. If you look at a meta-analysis of the effects of hormone therapy with estradiol on fracture risk, say in the hip, it reduces it about 30%, in the vertebral bodies about 40%. If you then look at the data on medications like bisphosphonates, for instance, or Prolia, the reduction of fracture risk in, say, the spine is upwards of 70%. And the percentage improvements are a little bit larger than they are with hormone therapy. Is it like this concept that once someone already has osteoporosis, we need something like even more aggressive? Interestingly, there are some studies that look at combining hormone therapy with bisphosphonates, so getting both, and you're getting basically the full additive effect of the two, getting an even greater improvement in bone density. I'm with you. I don't really understand why that's not necessarily considered an option. And also, there are so many people that I think over time, as more and more women are on hormone therapy and stay on it for longer, there may be people that start on estradiol and stay on it, but then need to add something else later on. And I think people will end up staying on estradiol for longer because the bone protective effect does go away when you stop the estradiol. So I don't think it's totally logical, except for the fact that maybe once you already have osteoporosis, you're no longer in the let's build some bone back or halt the loss situation. You're like more significantly in need of a larger fracture risk reduction, perhaps. But
Right. Now, what I read about the FDA approval bit was that the cohort of women that's been studied so far is, even though we do have this huge, robust evidence of estrogen
Mhm.
supporting bone health and fracture prevention, there aren't adequate RCTs or randomized control trials on women with only established osteoporosis, like including the WHI was
Yes.
basically general population. They didn't isolate women with
Hmm.
osteoporosis. And
And most
that's
studies are on women that start taking hormone therapy within 10 years of menopause because that's what was now presumed to be safe. And so, like, many of those women are going to be osteopenic, not osteoporotic, or maybe not even osteopenic yet, and you're trying to prevent them from getting there. I do the concept that estradiol is the preventative, is prophylactic. Like, we'd like to be, and that's the thing that I think so many people don't realize when they're like making a hormone therapy decision is about preventing osteoporosis. I think most people, I think probably the majority of women don't realize that is one of the indications for that medication, that you don't have to be having hot flashes or night sweats or vasomotor symptoms or whatever to be indicated for that. You could just want to preserve your bone density. But yeah, most of the studies that showed efficacy in fracture reduction, yes, they were done on women, many of the, other than the ones in the Women's Health Initiative that were more than 10 years out that then muddied the data some. Yeah, mostly they are done on women earlier in the postmenopausal setting. So
About, you mentioned earlier that getting off hormone therapy means there will be, most women do go back to their original bone mineral density over the next 1 to 2 years.
you get back into that higher rate of decline. So
Mm.
the benefit doesn't stay with you forever, because then you get back into that loss at that rate that's closer to the 2%.
What should be the strategy then? Would it mean getting this, let's say a woman who had a T-score of minus 2.8 to begin with, or sorry, let's just use a T-score that's osteopenia. Let's say a minus 2.1 is on hormone therapy to prevent her from getting osteoporotic. Maybe she took it for 5 years and decided now she wants to get off it. Would would there be a consideration of getting her started on other drugs to prevent her from becoming osteoporotic?
There is a very good study that was done, published in JAMA on zoledronate. It was called Infrequent Use of Zoledronate, and it was on women who were actually osteopenic but not osteoporotic, menopausal women. And they looked at women who got one dose of the zoledronate infusion versus women that got one at time 0 and one at year 5 versus people that got placebo. And then they checked their bone density and fracture risk basically at 10 years. And it was really effective. So that's a very infrequent use of that medication. So if someone says, I don't want to be, I'm not sure, I think more and more people are like wanting to be on hormone therapy for longer. But if someone wanted to do something that was not overly taxing on them, like not such a huge intervention, and the difference between the infusion one time versus 2 times over the 10 years wasn't huge, but that could be something that someone could consider. So
Wow. So
trying to remember the
I think,
exact statistics on it in terms of how much it reduced risk. But I have it, actually looked it up for you because I knew you were interested in this, because I knew I wouldn't remember this. Okay. So I'm going to read this to you because I reread this study. I reread this study yesterday just for you. Okay.
Thank you.
In the group that had 2 doses in 10 years, in the osteopenic group, the risk of major osteoporotic fracture was reduced 40%.
Wow.
In the group that had 1 dose in 10 years, it was reduced by 29%. So you could have just 2 doses of zoledronate over a 10-year period. So spread out by 5 years, you can reduce your risk of major osteoporotic fracture by 40% as a postmenopausal osteopenic woman.
Wow.
That's a pretty high return on investment.
It is. And this wasn't on women who were on hormone therapy earlier, was it? Or it's just basically women with osteopenia?
Yeah, women with osteopenia, but it speaks to your question. If you're a menopausal woman with osteopenia, that study shows you can significantly reduce your risk of fractures without being on that actually annually. That's pretty limited use of that medication.
It is. Considering long-term use, could you walk us through some of the side effects of using bisphosphonates over long periods of time? What are the concerns?
Yeah, the classic one that everyone thinks about is Fosamax, like the oral one that you take once a week, and that can cause a little heartburn. You're not supposed to lay down for a little while after, you don't take it right before bed, that kind of thing. The big scary one that anyone thinks about with bisphosphonates is mandibular osteonecrosis, which is really rare. And the efficacy of these medications in terms of reducing fracture risk is very high. As the actual fracture risk reduction, if you're actually someone with osteoporosis, is much higher than those numbers I just quoted for you with osteopenia, because people with osteopenia are not as likely to break something. But one of the things that people really worry about, and again, they're not extremely common, but we do see sometimes, are these atypical fractures. Sometimes, what happens is, like with normal stimulating effects on the bone, if you're doing load bearing exercise or strength training or using stimulating bone density through use, you get a more normal architecture of bone. It's getting remodeled in response to load. But with the bisphosphonates, they basically inhibit some of that resorption. And so maybe you get less, I don't know, natural remodeling, I guess. So the remodeling is less in response to stresses on the bone. And sometimes we see these fractures that are, instead of being at the actual hip, where you think of a traditional hip fracture, they're just below the hip. And we think it may have something to do with the architecture of the bone that we see sometimes with prolonged these medications. And so that's called an atypical hip fracture, or in fancy words, we call it a subtrochanteric hip fracture. And you just have to fix it differently with a rod down the femur instead of, like a partial hip replacement or something like that, or pins in the neck of the femur. But so that is one concern. But they are incredibly effective medications, and something that you can have in an infusion once a year has pretty high compliance as well. And I think so many people are like, their goal is to never need a medication for osteoporosis, but there are times when, if you look at someone's risk assessment, if you look at their FRAX score, for instance, a tool that we use to judge risk for having a major fracture, like sometimes when you're weighing risk and benefits, it is in favor of using one of those medications. I don't think people should see that as being like defeated or failing or something like that. Like sometimes that is, needed. It doesn't mean you can't do other things for yourself. But so those are certainly not prophylactic medications. They're responding to the problem. And the other thing is, we often are sending people to be tested for osteoporosis after they have a fracture. That's how they figure out they have a fracture. And then by then it is not enough to put someone on hormone therapy, or they're much farther out from menopause, or they have much worse osteoporosis. And they do need those medications, especially if you're talking about like a hip fracture, because those occur so late in life sometimes, as opposed to something like a wrist fracture, which those really start happening to women in their early 50s. And so if someone falls and breaks a wrist, and then we send them for a DEXA scan and they have some score, let's say they're osteopenic, but we catch that before, we didn't wait until they were 65 or had a hip fracture to check a DEXA scan. Now we can be prophylactic. We can educate on, the benefits. If you're able to use it, estradiol can help slow the progression or help you gain some density back, and all the other things you can do. So I think the problem is, like, a lot of times we're responding to an injury, and sometimes by the time you see this person with this injury, they're already like well into osteoporosis, and then they do need, that type of medication.
And I guess there's also utilizing that window of opportunity when it comes to hormone therapy, right? That under 60, and it's not that we're not using it post 60, but the benefits usually outweigh the risks in that group of women under 60 and within 10 years of menopause. And if you're going to do DEXA tests, scans so much later, then we've gone past
Missing
that.
the time. Yeah. And I think like people would make a decision differently if they had information. If you happen to find out you already had osteopenia when you're 52, you might make a different decision than if you had normal bone density at 52. And actually, I haven't tested my DEXA yet, but if I have normal bone density at 52, I'm still going to use transdermal estrogen because I know it's going to decline, and I know of other benefits, and I can. Not everyone can, but I can. But for some people, that might help them make a decision.
No, absolutely, absolutely. Yeah, my DEXA scan was my big decision maker for me at 51. And I was already 6 years post-menopause then, almost 6 years. I was not on hormone therapy. I thought I was thriving. I was full-fledged. I had so much faith in lifestyle and what I could do for myself. And that DEXA scan was a slap on my face. And I was like, if despite doing everything that I think in my power, and coming back to what you said about good health isn't a gift, it's an accomplishment. But that accomplishment, I feel hormone therapy became one of my tools to add on to everything else that I was doing. But I was again fortunate to be able to use hormone therapy to still be in a good window to utilize its benefits. And that's why this episode is very close to my heart, because I feel women need to be proactive and be a little, I wish I had done things differently. I'm still glad the way things turned out, because it made me push every bit of lifestyle I could, because I had not, I didn't have hormone therapy to take care of my symptoms. But at the same time, I feel I could have saved myself a lot of trouble.
Yeah. Every patient I see that's a midlife-ish woman, it doesn't matter if they're there for their rotator cuff tear or their like knee pain or whatever, I tell them about the bone health benefits of hormone therapy, and also that, about reduction of joint inflammation, which is a less fleshed out benefit, but I do think is real. And like it's amazing the number of times that an orthopedic condition connects back to midlife health. And I sometimes feel like I'm like, I don't know, a gateway to women's health, because people are coming in with joint inflammation. And then it leads into the discussion about preventing osteoporosis, but they're also having other issues like the normal vasomotor things. And I just, send them over to my women's health partners who luckily are across the hall in most of the offices that I work in. But
Oh, that's wonderful. That is really wonderful. But coming back to the treatment bit is if you're talking about some of the other drugs, like from what I understand, and if you can explain some more, is we have a limited number of years that we can use any of the drugs that are currently available for the treatment of osteoporosis. Is that correct?
or if you use them for several years in a row, you can do a drug holiday from them. Again, so you don't get into that, something like those atypical fractures. Now, some types of medications are meant to only be used for a couple of years, like the parathyroid hormone analogs, like Forteo and things like that. And those actually, like some of the drugs that build or are building bone, not just blocking the breaking down of bone, when you stop them, though, the problem is that you get this rebound. You can get a rebound osteopenia where the bone density can then drop rapidly, and then you can be at risk for fracture. So actually, like that class of medication, you have to then follow it with a bisphosphonate to stabilize the bone density. I think really most commonly what I see now are Prolia and Reclast or Zolendronate, the once annual infusion of bisphosphonates. And then I see a lot of utilization of Prolia now. Those are both very effective medications.
And then I'm sure they have a great role to play in a lot of areas, but I guess the goal here is to bring out that we can prevent it and to think about hormone therapy if that is one
Yeah.
of the tools that you do want to consider. Now, if I were on hormone therapy and if I wanted to, let's say if I have a T-score of -1.8, I get on hormone therapy, how do I know that it's making a difference? Do I need to repeat a DEXA scan? And is there any role for the blood markers that are recently being used? C-terminal telopeptide and the P1NP, is there any role in using
Yeah, like
those?
signs of bone turnover. Yeah, you can follow your bone density. And again, I think it's helpful to have the trabecular bone score with it every couple of years and see that it's improving or staying the same or not. But yeah, I don't, we work with our endocrinology partners who then follow our patients with the subsequent scans. And I don't know how heavily they're relying on bone markers at this time. But yes, those are markers of bone turnover. And I don't know that you would adjust the dose of these
Dose accordingly.
medications. The like the Prolia and Reclast are pretty common doses. There is some question about, I think, dosing of hormone therapy and what strength you need to stop bone loss or to gain bone back. And this is why sometimes you'll hear that some people are checking actual estrogen levels, because
Right.
there are some levels that seem to be associated with not losing bone or gaining bone. And I think that is maybe has more direct feedback on how you might then, if you're going to try to achieve certain levels, how you might then adjust the dose of that. But I also think we know there's a ton of data on doses of like transdermal, even a transvaginal estradiol that do seem to increase bone density. And then there's like a moderate and a full dose where you don't see such a huge difference. I guess if you're like a really poor absorber or you're not seeing improvement over the course of time, you could check to see if you're a poor absorber. But I don't think it's currently standard of care to be like looking at bone turnover marker labs or even necessarily estrogen levels, just based on an understanding that for most people, these 50 microgram doses are adequately increasing bone density, and even 100 micrograms does a little more, but not that much more than 50 micrograms per day,
And
basically.
then there's a trade-off.
Yeah.
There's a trade-off what happens beyond that with also the rest of the body, the side effects of being on higher doses and what is it doing to the rest of your system. But yeah, so estradiol levels, I don't think we still have enough data to say this is definitely the level we want our women to be on as
Yeah.
well. Yeah, yeah. If we were to, and of course, like women who have contraindications to the use of hormone therapy and
Mhm.
or would not like to use hormone therapy at all, there's still prevention. There are still other ways of preventing
Mhm.
bone loss. And you can see from all the lovely content you put out on
Yeah.
social media, on your Instagram handle. For those of you who
Yeah.
haven't seen, should definitely go see her.
Yeah.
Jocelyn Wittstein, MD,
Yeah.
that's
Yeah.
handle.
So I think it's helpful to think about. So, first of all, there are a lot of people who, for various reasons, cannot use hormone therapy or have been put into an early menopause state, either surgically induced or maybe with aromatase inhibitors, things like that. And that's that's a bad side effect of those situations. And I do think, just for perspective, like the statistics that are easy to quote are very well known. Like the Lift More trial was one. It was an 8-month intervention where people were able to gain 3% in their lumbar spine bone density. So that's just 8 months gaining 3% versus some of these trials of medications are 3 years where maybe 5 or 6%, including some of the estradiol trials are gained maybe 6% over a few years. So gaining 3% in 8 months from something that has other health benefits to you is amazing. A study showing that 6 months of a jumping intervention helped you gain 1% in your hip it sounds like such a small number, but it's not insignificant when you think about the fact that drugs like zoledronate are increasing bone density on the order of something like 7%, right? If you're just doing some jumping, you're getting 1%, and then you're adding in the strength training. Like these are things that you can do that add up to real numbers and that you can continue to do. And then also, while we do care a lot about bone density, we also know that there are some interventions that even in the absence of increasing bone density, they still dramatically reduce fracture risk. There's a study I've quoted on walking 35 minutes a day that looked at large populations of women starting who didn't do the regular walking and who did, and they followed them for years and years. And even though walking doesn't necessarily increase your bone density dramatically, there's something about walking that if you're a regular walker, if you go on a brisk walk 35 minutes a day, the study that I've quoted showed a 41% lesser risk of having a hip fracture as compared to people that don't do that walking. So there's something about some activities, even though they're not increasing your bone density or maybe not dramatically slowing the decline, there's other benefits like muscle development, balance, coordination, and mobility, which are the other pieces of not breaking a hip. It's not necessarily just your bone density, because the other piece is you have to not fall.
Right.
Yeah.
And I think that link, that the connection between bone mineral density and fracture, just because you have a lower density doesn't equate to a fracture. Having
Yes.
normal density doesn't equate to you will never fracture,
And
right?
even different changes in percentage of bone density for different pharmaceutical interventions doesn't necessarily equate to the exact same fracture risk reduction. So they're just different mechanisms. So we get a lot of these numbers of this medication increased bone density this much and had this much fracture reduction. And the trials are over different periods of time and different medications and things like that. But I don't think we should dismiss things that necessarily don't create an increase in bone density, but also reduce fracture risk. Like the EFOPS trial is one, which was done out of the Netherlands, where they had people that they followed for 17 years who had one group had this exercise intervention that included some strength training and some agility work and some jumping and things like that. And then the other group had like a control exercise intervention. And early on in the study, they did see that these people had less loss of bone density or maintained their bone density more. But over time, that difference in bone density kind of trailed off. And even though they weren't able to maintain over time as much of an improvement in bone density, the exercise group still had the 50% lesser risk of fractures than the control group. So with some of these non-pharmaceutical interventions, the risk of fracture or the reduction in fracture risk isn't necessarily tethered exactly just to bone density. It can be things like balance and bone quality and mobility. I think the way we think about fracture risk reduction with pharmaceutical interventions, it doesn't exactly perfectly translate to
Mm.
exercise interventions. And if we thought about exercise interventions that way, we would never walk, or there's all kinds of things that don't necessarily, they're still a use, even though they're not disuse of your lower extremities. Why would anyone ever go on walks if it doesn't increase your bone density? If you just sat in a chair all day or used crutches, you would really rapidly lose bone density in your legs. So it's just, I don't think we can apply the same standards of pharmaceutical interventions to exercise interventions.
No, absolutely. And
Although
even
it's
if one
nice
is,
to see that some of them do increase bone density.
of course, and
Yeah.
again, once again, it's about holistic care. We may
Yeah,
need pharmaceutical intervention, but
you may.
just being on hormones doesn't make any woman unbreakable. And I think that's also important for us to
Yeah,
understand.
you can't just take this medication and just be like, that's good. Yeah, it's the same thing with using creatine monohydrate. You're not going to get strong just because you took some creatine. You would also have to go do some strength training.
Absolutely.
Yeah.
Absolutely. All right. Okay. I think we have covered quite a bit of what I wanted to
Yeah.
ask. I can go on with this conversation for another couple of days with you because I have so much to learn about bone, and it's always nice to hear
Yeah,
different
yeah.
perspectives. But if there were 3 messages for our audience today about prevention of osteoporosis and prevention of fractures, what would you have to say?
I would say if your joints and your tendons tolerate it, incorporate some strength training a couple days a week. If your knees and hips tolerate it, incorporate some jumping a few days a week. If you don't have contraindications to it, transdermal estradiol is very safe and very effective as a prophylactic measure against osteoporosis. And you only asked for 3, but I'll give you one more. If you didn't start early and you feel like you missed the boat prior to 30 or even in your 40s or 50s, it's really never too late to start. There are tons of studies that are on women in their mid 60s utilizing lifestyle interventions that show major benefits in terms of reduction of fracture risk.
Wonderful. Thank you so much. This has been so much fun chatting with you, and there's so much information, and thank you for sharing all your insights with our listeners. There's lots of benefits, lots of tips to take back home today.
Yes. Well,
Thank
thank
you.
you for having me.
Thank you.
Thanks again for tuning in to MenopauseWize. Stay informed, stay empowered, and I'll see you in the next episode as we continue to navigate the menopause journey together. If you're a healthcare provider interested in collaborating with us or have insights to share, we'd love to hear from you. Please email us at info@menopausewize.com. That's wise with a Z. And before we go, a quick medical disclaimer. The information provided in this podcast is for educational and informational purposes only and is not intended as medical advice. Always consult your physician or a qualified healthcare provider before making any decisions regarding your health or any medical treatments discussed in this podcast. While we strive to provide accurate and up-to-date information, this podcast does not replace professional medical consultation, diagnosis, or treatment. If you have any concerns or symptoms that require medical attention, please seek advice from your healthcare provider.